as a cardiologist since 1990. And I went to medical school, did my training in the 80s. So I kind of feel like I grew up with this subject a little bit. I mean, I remember as a medical student and a young intern resident going to lectures where they were talking about this subject. And I was young and I thought, no, there's no difference. I mean, you know, us girls, we're the same as these guys. And I really kind of didn't get it until I started to age and mature. But I mean, as I went through the decades of aging and saw much of what is different. And so I'll go through some of that with you and maybe talk about the history a little bit. Maybe 30 minutes at the most of these slides. But I got a lot of time for questions. So feel free to, you know, keep track of them. If you want to interrupt in the middle, that's okay too. Would this help? Let's see. How's that? Does it make any difference? Go enough higher? You can. Okay. Good. All right. Now I have two gadgets to hold on, keep track of. So we'll see how I do.
Sorry.
So I apologize. Part of some of these slides I've used for other things, and you're going to see this abbreviation SIHD, like you see in that top line. It stands in Dr. Lingo for stable ischemic heart disease. When you see that, you want to just think of cardiovascular disease, the basic subject we're talking about. So we're going to talk about some of the differences between men and women, the gender-related patterns and differences. In general, and it continues to be, cardiovascular diseases, these diseases of the heart and stroke, continue to be the leading cause of death for women and have been for many, many years. When it comes to heart disease and stroke, there is a little bit of a misunderstanding with some of these differences we've talked about. And sometimes I hear patients and other people say, well, she's having chest pain, so it's probably not her heart because she's a woman. Like women can still have typical chest pain symptoms and angina symptoms, similar to what we've always taught. And it is actually a very common presentation of heart disease in women. Maybe the difference is that women also will mention several other symptoms with it. So they have many additional symptoms, but heart disease and chest pain symptoms, angina symptoms in women are still very common. But one difference is that women show up a little later in life in terms of their symptoms and presentation with heart disease. They show up at an older age than most men do. Is it impossible or, you know, unheard of for a woman, maybe a premenopausal woman, to have heart disease? No. The youngest, most unfortunate, one of the more unfortunate patients I've taken care of was still having her periods, was in her mid-30s, and had already had 2 stents. So there are, you know, some unlucky younger women, and there are things that we need to do differently for them. So it is possible, but most of the women that we will see will be in an older age group than most men. They are less likely to be diagnosed and treated. So I'll show you some examples of different studies where they've talked to women who had heart attacks, and afterwards they talked to them about it and said, what was it like when you were in that emergency room? What did they think was going on? And something like 24% of them will say, and tell you honestly, that the doctors and nurses that were taking care of them immediately told them, well, we don't really think it's your heart, but we're checking things anyway. You know, just kind of like we need to kind of open our mind sometimes, some of the physicians and nurses taking care of patients, to the rather atypical presentation that sometimes women can have. And women, unfortunately, have higher cardiovascular mortality. What's that mean? If you're looking at a group of men and a group of women who have cardiovascular disease, heart attacks, different things, the women, unfortunately, don't have the same, they have a higher risk of dying from it than men. So that's what we need to keep working on. And unfortunately, they always put these money slides in, right? It costs a lot of money for our healthcare system taking care of heart disease in both men and women. Well, this is a friend of mine and somebody I admire quite a bit. Nanette Wenger is, she won't ever tell anyone her age, but I believe she's in her early 80s. and still practices. She's been just a pioneer cardiologist and has done wonderful things. She's out of Atlanta. And she has really seen a lot of history when it comes to medicine and women and heart disease. And that was something that she said about 15 years ago. And initially people said, well, how dare she say this bikini approach thing? But it was very appropriate. You know, women thought they were doing everything right if they got the pap smear and the mammogram. And so they like, we're done. I got everything checked. I had my yearly, and that was all they used to have. And we know better now that women need more than just pap smears and mammograms. Well, here's what kind of caught a lot of attention and stimulated a lot of research and a lot of discussion and a lot of discomfort among some groups. And what this is we in cardiology are very proud to be able to tell anybody who wants to know that heart disease can be prevented. And once diagnosed, we have been able to make a huge difference and an impact for patients in terms of their mortality. So yes, we are saving lives. Every year we save more and more lives. And if you look since 1980, and this is the numbers in thousands of men and women in the different lines that have died as a result of cardiovascular disease, you can see we've really made a big difference. And before separating that out for men and women, it was a nice looking line that went like from here, and it would just kind of go down like this. And everybody said, wow, we are doing a great job because we are reducing cardiovascular mortality dramatically. And it is true, we have done a great job. But what we realized when we separated it out for men and women is that we're not getting near the benefit that the men were. And there were some periods of time here where the women's mortality was even going up. And it was really about this time that people like Nanette Wenger bringing our attention to this bikini approach to healthcare for women, and some of the federal programs started to fund research and development in trying to get at what are we doing wrong in terms of heart disease in women, and what can we do differently to get them the same benefit that we've been able to give men. And as you can see, we have made some real good improvement and strides. These numbers continue to come down, still more dramatically for men, but I'm really impressed and really happy. I mean, I've been doing these lectures a long time, and I didn't used to get to show this part. We've made a huge difference in the last 10 years, and we think it's a combination of getting women educated, and I think the Go Red campaign has helped a lot, and I think healthcare professionals, physicians, people taking care of women are starting to pay more attention to cardiovascular risk. Well, this is kind of a crazy looking slide, so bear with me, because just to make a point. One of the things that we do in cardiology is we look at a patient at whatever age, and they'll come in and they'll say, what's my risk of having a heart attack or a heart problem? And so we look at these little calculators and we give them a 10-year risk. So if it's someone who's 35, we tell you, well, between now and when you're 45, you have this risk of having a heart attack or a heart problem or whatever. But then, really, if you're 35, you're not, people want to know what's my lifetime risk too. They want to know what's it going to be for when I'm 75 up until now. So we look at these other things called lifetime risk. Well, one of the things that happens is as we age, and if you can see here for the men, this red column is the high 10-year risk. So they came in to see me, somebody who was 50 years old, and said, what's my risk? I do a calculation based on his cholesterol and his blood pressure and his weight and everything, and I say it's either high or low or medium, and these high-risk patients we get identified for the men, and then we start really aggressive treatment. Get that cholesterol down, go after that blood pressure, and get exercise, and do all those right things that you need to do for risk factors. But what happens, and as you can see, as they age, we have more men that get at that high-risk group, and we can identify. But for women, it never worked well. Maybe in 5 years when we do this lecture, it'll work better because we'll have different tools. But those tools and those kind of estimator tools that we use to estimate risk for men and women were not reliable at all for women. So we were having these women, as they're getting older, they'd come in and they might ask the same questions that the men were asking, but we weren't finding very many of them that were high risk. So we weren't able to initiate really life-saving treatment to prevent heart disease. And that's one of the problems that we have known of, and this continues. There's a new risk estimator that was just released last fall that came out with the new cholesterol guidelines, and it is being projected as being much more accurate at predicting risk for women. So if you hear your doctor talk about your risk, or there's any discussion of it, see if they're using this new risk estimator. It's something that you can Google and download yourselves and put them on our iPhones. It's really helpful, but it's recognized and tried to kind of clarify and help us estimate risk for women more accurately. This is just a slide that just showed how many women show up with symptoms of chest discomfort or chest pain. And these were all men and women who had heart attacks. And they were hospitalized and had myocardial infarction. And you can see that it's still a common presentation, chest pain is. So just if somebody said, well, it couldn't be their heart, because it's a woman, they don't have chest pain. Now, you know, women will continue to present with chest pain, and it's important to recognize that. But what I think is more impressive is that of all these women who were hospitalized and had heart attacks, 24% of them said on arrival or in their initial treatment that the healthcare providers really didn't think their symptoms were related to their heart at all. And they were kind of poo-pooing them. So this kind of shows us that a lot of these symptoms, even when they include chest pain, are still considered different or atypical by those treating the women in the hospital. And then unfortunately, and this is something that's still not completely understood, sudden cardiac death, which is one of those heart attacks that makes you drop dead. You know, when you say, oh, he didn't even make it to the hospital, he or she had a heart attack, they died suddenly, that's sudden cardiac death, is much more common in women, unfortunately, than it is in men. And especially in symptomatic women. So women who continue to have chest discomfort symptoms that are not well controlled have a higher risk for that. So as we age, there's a frequency of angina symptoms in both men and women. You can see the yellow columns are the women, the blue are the men, and you know it's more commonly seen in older groups, and as we continue to age, we see it more. This is just a slide that shows in men and women when you're in a hospital getting some of the invasive tests like the angiogram for your chest pain or heart attack evaluation, what the risks are of dying from that. So in the United States for many, many years now, all these things are tallied. If somebody goes to the hospital to have a heart cath and they don't come out successful and they die, that is something that has to be reported. And we have all these registries that keep track of all these numbers for statistical reasons. And in fact, it's been demonstrated in all ethnicities that women, no matter what age, what group, they have a higher incidence of mortality associated with any of these procedures. So they are a higher risk group when they go in and have the procedure performed. So about that time when they started to recognize that women were not getting the same benefit as men, the federal government funded a very pivotal, pretty famous study now called the Women's Ischemia Syndrome Evaluation Study. And what they did is they looked at women, and there was over 900 of women who had some type of chest pain symptom. And they had gone to their physicians and had a stress test, and the stress test was abnormal. It came back saying the stress test, you plugged your stress test. And so their next recommendation was, well, we're going to schedule you for an angiogram, a heart catheterization at the hospital. So they went for the heart catheterization, and this study enrolled that type of woman. So they could follow those women and see, is there something that we can get at to try to help understand the differences and hopefully try to increase our understanding of the treatment. So that's what this study was. They looked at these women, some 900 some women. Now they were all women with chest pain. They had all had stress tests that were abnormal. So then they went in for their heart cath. And after the heart cath, one of three things was demonstrated in terms of the categories of the study. Either they categorized him as a woman who had no significant coronary artery disease or blockages in her arteries, and that's good news, and this is what that category was. Or the doctor came out and told her family that, you know, she's just got some minor stuff. You know, we're going to treat it with medication. It's not major. It's a small burden of disease. And that was this number of patients. And then obstructive or more significant coronary artery disease, where there was blockages in maybe all 3 arteries. And so you would kind of think that then the study said, we want to follow these women in these categories. And we're going to follow them for 4, 5, 6 years and see, you know, who did the best and who lived the longest. And so you would immediately think, as we did at the time, that the women who had no blockages, right, would live the longest and have the least amount of symptoms. And that the ones with lots more blockages would have all bad problems. But what we found out that of those women who were told they had no significant blockages, when they tallied up the numbers over the next 5 or 6 years of the women who had died, there was a significant number, let me think what it was 11% of them, I'll get the absolute number of how many died of a cardiovascular death in that period of time, which was 6 years after the angiogram. And of those who had died, some of those were in the group, and a significant number of them were in the group that had been told they had no significant blockage. And in fact, the ones who had the most blockage, you know, significant severe disease, they said, had the most number of deaths in that 6-year period of time. But it was not insignificant, and it was completely unexpected. So this really kind of rocked and shocked the cardiovascular community for several years, getting more and more funding to try to get at this. And I'll show you the explanation of what's been determined years later to explain it. But what's important for us to understand and to know is when we do these angiograms and they inject this dye in an artery, sometimes it just looks like a nice smooth tube. And then when people look at that smooth tube, they don't see anything that looks like a hourglass or a significant blockage. They're compelled to say, well, that smooth tube looks normal. But what we've realized years later is that sometimes, unfortunately, more often in women, you can have just a diffuse narrowing, kind of like a bad pipe. You can just have a smooth inner area that's just narrowed the vessel to about 30, 40, 50% of what it used to be, but it can still look smooth. And that's what we call this diffuse, non-obstructive disease. Ischemic heart disease, and it's more and more common in women. So probably what happened years later, looking back on it, was that these women who were told, oh really, you don't have any significant blockage, you go home, have a nice life, they weren't given any additional treatment. Probably, in fact, they really did have blockage there. It just wasn't like in one spot where they could see it real dramatically like a cutoff. It was just this smooth, non-obstructive atherosclerosis. So, in general, the more symptoms a woman or man would have, the more higher their mortality rate is. So that became a very important hallmark feature of the study, is that even when they were told that, you know, there's really not much there, they said, well, if this patient is still coming back and having symptoms, more chest pain, more chest tightness, whatever their symptom was, that should prompt more consideration for that woman needing more treatment. And that's, I think, what we learned the most from this study. So these are different studies that we looked at, and this is a Chicago-based study, but the more risk factors you have, the more risk you're going to have of having heart disease and having maybe a bad outcome from heart disease. I think, is that door locked? Maybe someone's peeking through. So, you know, it's just common sense, and we continue to preach and we continue to try to work with women and men to reduce risk factors. So, you know, we want everyone to quit smoking. That goes without saying. We want men and women to exercise every day, 20, 30 minutes. It doesn't have to be a fancy health club exercise. It could be just going up and down your stairs at home. It could be a nice walk. Whatever you can incorporate into your life that you can continue to do every single day is what we ideally like to get at. And then cholesterol numbers are vitally important. We have patients that are identified at very young ages that have marked abnormalities in cholesterol that we know if we start treatment earlier, we can really impact on their risk. Diabetes is a huge risk factor. We want those numbers well controlled. Blood pressure, We all know that one is a risk factor. And then the toughest one of all, right, is weight. And we have to keep working with women and try to incorporate new things to try to get women to figure out ways to control their weight. I'm going to go through a few of these. There's other, less traditional risk factors, though, that we see in women that we don't always obviously see in men. The traditional risk factors are the ones I talked about. The cigarettes, blood pressure, diabetes, cholesterol. We know those risk factors. Age, we can't really do much about those. But there's some others that women have been known to demonstrate. Hormonal things can influence the development of heart disease. So it's one of the reasons we see most of the heart disease in women, or at least larger numbers, after menopause, because the drop in estrogen seems to have some changes or unmask some changes. There are some women who have abnormalities in hormones at younger ages, this polycystic ovarian syndrome, which is an abnormality of hormone balances, but includes extra testosterone. And we could see and have been able to demonstrate in these women who happen to have that abnormality or that disease that they have higher risks. And so they're a group that we didn't know about years ago, and now should be identified and watched more carefully and treated. There are some other novel risk factors: the C-reactive protein, abdominal obesity, and then after menopause, it's real important to watch every woman, even if everything's been perfect for that woman. After menopause, every woman really needs heightened attention, because it is a time when women present and tend to have like a clustering of risk factors. Blood pressure even if blood pressure hadn't been up earlier in life, after menopause, sometimes that's when women show up with high blood pressure. Same thing with cholesterol. And unfortunately, it's a time in life when it's really difficult to control your weight. So it's sometimes a time when the combination of all these factors can lead to increased risk for a woman for cardiovascular disease. But it's a real spectrum with cardiovascular disease. As I said, there are younger women that weren't identified years ago. And we've recently learned some things to watch for now. We know the obesity situation. We know that this extra weight is really a significant risk. And you know the blood pressure, diabetes, cigarette risk, and cholesterol, and that POS is that polycystic ovarian syndrome. But the new information that we've learned in the last 5 years, or maybe a little bit more, is that pregnant women, pregnancy turns out it's like a stress. We knew it was a stress test when we were pregnant, but I mean, it's a stress test for women. So if during pregnancy a woman has either diabetes or has to be treated for gestational diabetes, if during pregnancy a woman develops high blood pressure or pregnancy-associated hypertension, or worse yet, preeclampsia, or even, moreover, if a woman's pregnancy ends with premature delivery, that woman really has been demonstrated to have increased risk for cardiovascular events for the rest of her life. So these women who have had these events during pregnancy should be followed. They should, it doesn't mean that you're going to end up on a pile of medicines or anything, but they should get extra attention as somebody who has increased risk and be given additional treatment when necessary. And then lastly, the inflammatory diseases, things like rheumatoid arthritis and lupus, all those autoimmune inflammatory diseases, they happen more often in women. And they can happen in men, but they're more frequently seen in women. And it's been demonstrated that those inflammatory diseases, that chronic inflammation, can lend to an increased risk lifelong for women for cardiovascular disease. So women have a whole lot of things and a whole lot of different things to look at than men. We're much more interested in general as a species. But for years, just kind of comparing us to the men, it didn't always work. And there was a lot of missed opportunities, which hopefully we're working on now. And then I mentioned the menopause. I mean, menopause is really a time that we just have to sit down and have a conversation with our doctors about what your risk is and what you can do to control that risk. So let's talk about angina in a few minutes. is angina? Angina is the old, term that's been given to the symptom that is related to not getting enough blood in your heart muscle. So there's lots of different descriptions here. Sometimes it's like a Hollywood heart attack. Somebody is clutching their chest. Oh, it's the worst, crushing chest pain. But sometimes it's just, somebody rubbing their chest, there's a discomfort there. Or sometimes it's a sensation of, maybe they don't want to use the pain word. Maybe it's like, I feel a little tightness, or I'm kind of just smothering a little. It's just an uncomfortable feeling. All of those things can be angina, and all of those things can be heart. I tend to tell people that any symptom above the waist, and usually below the mandible, but any symptom above the waist, in one way or another, upper back, shoulder, arm, all these things can represent heart symptoms. Things that typically precipitate angina are exercise, cold environments, if you've just had a big meal, go out for a fast walk, emotional upset, fright, anger, and sexual relations. And classically, it's supposed to be a symptom that will get better with rest, or if somebody gave you a nitroglycerin pill. So those are the ways that we kind of work with the definition and help diagnose and define whether a person has angina or not. But then there's other things that we take it further with, and we say, well, is it typical angina? Is it, just this clutching, pressure, tightness, pain, pressure in the chest that came on after going up the stairs and was relieved with rest? Or is it something kind of vague? Is it somebody sitting there telling you, no, it doesn't really feel like pain, it's just, I just get short of breath, or and then if we kind of push and try to get at that, and hear that, well, it was some discomfort that occurred with an activity that may well be an anginal equivalent. And that atypical presentation is something that's more commonly seen in women, and that's one of the reasons we have gotten this, description that, they don't have chest pain, they have all these other things. Well, they certainly have chest pain, but they can also present with some of these other more vague or difficult to describe symptom complexes. One thing that happens, especially with women, I think, if I run from here to the end of that hallway and did it real fast, that I can get uncomfortable here. But then if I quickly figured out that if I just take it at a half pace, or if I stop halfway and pretend I needed to get a drink of water, then it won't bother me. People adjust their activity levels to decrease the frequency of symptoms. And men and women do that, but women do it pretty frequently. So if you have a friend or family member, or maybe yourself, who routinely used to walk from your car into the grocery store, or your car, whatever the situation might be, who you are now noticing, gosh, I can't walk that far, can you find a closer parking spot? That's somebody you should talk to. That could be somebody who's developed this symptom and is trying to avoid the activity that brings it on, but probably needs to be treated and evaluated. So we do that. We're kind of considerate as a gender. We don't want to, we don't. But yeah, we need to be aware of that, and treat that. These are lots of different things. I can move on a little bit. One of the first things that we want to do when we can't know for sure, somebody comes in and it sounds like they're having angina symptoms, we want to evaluate them with some type of a test to prove or disprove that it might be something from their heart. And there are numbers of ways to start. Usually we do some type of a stress test. If someone can't exercise, we can do it as a chemical stress test. But the best stress tests, if you're able to exercise, are done with exercise. What's different for women is that depending on your hormonal situation, it can influence, believe it or not, the EKG is actually influenced by hormones at times. So some younger women who might be at different phases of their menses have an EKG at the beginning of their cycle that's vastly different than what's seen on their EKG 3 weeks later. That we've realized that estrogen can actually influence some of the changes on EKG. So that's something for us to remember when we're trying to evaluate women in that age group and consider additional imaging tests with it. Symptoms, again, can vary with the menstrual cycle. postmenopausal women, after all of the hormones are kind of not in flux as much, are a little easier to evaluate, so the stress tests are more reliable. But one thing that's a problem, some women, and men, but I mean some women, they can't exercise anymore. They quit exercising, or they just, arthritis or something else keeps them from exercising. And the diminished ability to exercise then becomes a risk factor, this inactivity. Unfortunately, it's one of the reasons that we want to continue to maintain some level of exercise. It doesn't have to be 2 hours at the gym, it doesn't have to be, but some level of exercise. You don't want the couch potato syndrome. So, sorry. Other things that we can do besides stress testing, there are some calcium scoring techniques and screening tests that you can have performed that can help us evaluate patients. But for the most part, the stress test is the most important and usually utilized in the evaluation. So I'm going to skip through some of these so we can get to some questions. But one of the other things that we've realized for women is, regardless of the size or age of the woman, if you look just at their arteries all over their bodies, including their heart, their arteries are a little smaller. So that's one of the differences in the evaluation, is that we've realized that women's arteries are a little smaller. They can get blockage in them, but it's usually a diffuse kind of narrow. So it's not a situation where it looks like the hourglass, where you just see this real pretty tight blockage that we would see in men. It just might be this narrowing that doesn't look so dramatic in an angiogram. And then they have different types of plaque. The plaque is sometimes not as stable. One of the other things is, because of those inflammatory diseases like arthritis and lupus, sometimes they can have more irritability of the artery. Excuse me. So we have the same excuse me, disease that the men get, but it presents in a different way. So this, I'm not going to go through the detail here, but you can see if you took an artery, a coronary artery in the heart, and if you cut it like a salami, we can look at the, the lining here. And this is the way it kind of looks for many women, is here it is cut crosswise, and this yellow stuff is atheromatous debris or blockage. But when you do an angiogram and you inject the dye, and this is what it looks like in the long axis, you can see it's just getting narrow. But when you inject the dye, I don't know if you can see it real well here, it still just looks smooth. It doesn't necessarily look like dramatic like us. The cardiologist wouldn't look at that and say, oh, there's a 75%, blah, blah, blah. I mean, we'd kind of say, oh, that's just kind of, a little diffuse disease. But in fact, there's plenty there to cause trouble for a patient or a woman, and frequently does. And that's why in those previous studies where the women were told they really didn't have much blockage, yet they were women who were in a group that still had a lot of risk for cardiovascular events and died, was that they must have had this rather smooth presentation, which is way more common in women. So prognostically, what we realized is even if you don't have any significant or major amount of blockage, if you're controlling symptoms, you're going to live longer. So the women in that study who had mild or just moderate disease, if their symptoms of chest discomfort were controlled, their prognosis was very good. If they continued to have lots of chest pain symptoms, unfortunately, even if they had only a mild amount of disease described, their prognosis was not as good. So I'm not going to go through any detail here in terms of the different medicines that we use, but women, whether it's diffuse disease or a tight blockage, besides all the things that you see in everywhere else with stents and interventional procedures, the mainstay of treatment for this disease continues to be medications. We have to continue to prevent it from getting worse, and if somebody has not manifested with any major event, like a heart attack, we want to prevent that from happening. So once identified as someone, patient-wise, who has, whether it's diffuse or focal stenosis or diffuse disease like we're talking about a lot of the women have, you should be treated. And the treatment includes several things, but generally categories of medications that include a cholesterol statin medication. There's different medications to treat the angina symptoms should you be having any symptoms. And then, of course, treating anything else that came with it, whether it be blood pressure or diabetes or any other risks. So those, and then aspirin is generally added for those that can tolerate it. So we want to treat with appropriate medicines. We want to go after these other risk factors, treating to specific levels. And then we want to prevent the symptoms from coming back, because we know that the women and men who have less symptoms will do better. So we're going to slow it down here. Just summarize. I know I threw a lot at you, and I guess my biggest message is 80% of this disease is preventable. So I have lots of friends that have devoted their lives to doing interventional cardiology. And it used to be that they were up day and night going in and taking care of heart attacks and doing angioplasties and putting in stents and all of this. And now it's kind of become shift work. And one of the reasons is because the numbers of procedures needed to treat this disease have decreased significantly. I mean, there's still a lot of work out there, but patients are understanding and being diagnosed earlier and treated so that we can prevent this disease. And in women, if we can only get at them earlier, before they present with a heart attack or an event, we really can initiate treatment and prevent the disease. So it's a very preventable disease. It's as common in women as it is in men. Angina or chest pain symptoms are still a common presentation. There's tests that we can use to diagnose the women. Sometimes we have to adjust them a little bit because of nuances with hormones and other things for those women. We have good treatment for them, but we need to continue to study the differences in women because there's probably going to be additional strategies and different things that we can initiate at different times for women that will continue to prevent this disease. So when I was in medical school in the 80s, most of the textbooks were illustrated by this we call them the Da Vinci of Medicine, Frank Netter. And medical illustrations in these textbooks. And this was Frank Netter's, and this was, I mean, I was in medical school in the 80s, and it had been there long before that, so I'm sure he probably published this in the mid-60s, probably, maybe 70s. But this was angina pectoris, his illustration of it. And that was how they taught us. I mean, it wasn't real purposeful that they were trying to avoid women, but it was just kind of how it was described back then. And so here it is, a middle-aged man who's out in the cold air, he's just had a big meal. If you look close, there's a cigarette in the snow there, and he just threw him down. And I call it the Hollywood heart attack. He's clutching his chest. Anybody walking by could see that, oh my gosh, he's having a heart attack. Something's going on. So, unfortunately, Frank Netter died, and there hasn't been a lot of additional illustrations to help these young medical students understand that maybe now, besides this gentleman, maybe now they need an illustration or a picture of a woman carrying a basket of clothes up the stairs, or picking up one of her kids who just fell off his bike and got hurt and is really struggling to do something. But we need images and we need reminders that this can certainly happen as frequently in women as it can in men, and unfortunately we'd like to prevent it. So in the spirit of Go Red, I'm going to show you this video. The American Heart Association took an attempt at helping us relate to it as perhaps it might be for women. And so I'm going to start this and see. Okay, so now I hopefully, sorry, I took up a little extra. I think that's